The left to right shunts. So basically, blood is moving from the left side to the right side. They are a cyanotic at presentation, and that cyanosis may occur years later. And then frequency is that the ventricular septal defect more frequent than the atrial septal defect, which is already more frequent than the PDA, patent ductus arteriosus. So the way a way to memorize it is that R to L, then it's RL, that is the early cyanosis, and then L to R, that is the later cyanosis. So basically, the idea of cyanosis is pretty simple. If we look at this image here, then let's just move it big, and then there you go. So this is the left side of the body. This is the left atrium, and this is the left ventricle, while this is the right atrium, and this is the right ventricle. So the right side of the heart pushes the blood, as we see here following this arrow, normally into the pulmonary artery. The pulmonary artery, which is here, gives the blood to the lungs where they to oxygenate it. So what comes into it, into the right side, is deoxygenated blood. So it doesn't have any oxygen in it. So basically, the blood in this part is deoxygenated in the right side, while in the left side, if I use this color, in the left side, in the entrance, what is coming to it are the pulmonary veins, and they already have a lot of oxygen because they're coming from the lungs where the oxygen has attached to the blood. So they basically enter the left atrium and then go into the left ventricle to go out into the systemic circulation. So the left side of the body has all the oxygenated blood. So this is oxygenated. So basically, what is happening if we have a shunt, as we said earlier, from the right side into the left side, like in here, that means blood, it's coming from the deoxygenated, should be red, deoxygenated into the oxygenated part. So that means the systemic circulation is starting to have a deoxygenated blood because it's abnormal. It's shunting to this side. So it's just shunting. So that means the baby is going to have early cyanosis because early after birth or prenatally, the baby is going to look blue. So if they look blue, that means the systemic circulation is getting deoxygenated blood, which means the blood is moving from the right side to the left side. So that's for the right to left, while if it's the contrary, this is the right ventricle, as we said, this is the left ventricle, this is right, this is the left atrium, as we said. So basically, if it's from left to right, then, as we said, all of this was oxygenated. So if it's coming this way, then it's fine. The baby is not going to have cyanosis earlier. Because the systemic circulation is just which is responsible for the cyanosis. For the baby to look blue is getting all the oxygenated blood from the right place, so there is no early cyanosis. So this is the simple idea of why the cyanosis is happening early in life and right to left, but it's not happening early in life in left to right. This. There you go. So the main disease, the most frequent one is the VSD, and that is a ventricular septal defect. So it's asymptomatic at birth because, as we said, there is no immediate feeling of oxygen loss because the tissues are getting all the normal oxygenated blood from the ventricles. So it's asymptomatic at birth, may manifest weeks later or remain asymptomatic throughout life, or sometimes it just happens for the person to go into life normally. Most self-resolve, most of those heal by themselves, but larger lesions, as in image C, may lead to left ventricular overload and heart failure. So as you can see here, this is the right ventricle, this is the left ventricle, and blood is just going this way. So this is an opening, that is the VSD. So this is considered a huge VSD. So basically the left ventricle is having a lot of blood during diastole. It's coming this way. So because there's already an opening, so it's just passing blood all the time. So the left ventricle goes into overload, has a lot of overload, and that may lead to heart failure. So the it says O2 saturation is increased in right ventricle and pulmonary artery. And this is quite obvious because, as we said here, the blood is coming from the left ventricle into the right side. So into right side, what opens here is the pulmonary artery. There you go. So the pulmonary artery, this is the right ventricle, has a lot now started to have some oxygenated blood coming from the left ventricle, and also the pulmonary artery that should have no oxygen at all is also getting some oxygenated blood from the left ventricle. And that's it for the ventricular septal defects. While the atrial septal defects is, as this image says, there you go, this is an opening between the left atrium to the right atrium. So that's where blood is going. So it's defects in the interarterial septum. There's white fixed split S2. So what it says here, that the ostium secundum defects are most common and usually an isolated finding. So the ostium secundum defect is something that we talked about in the embryology, and that should be somewhere in here. So so the septum premium is this green thing. This is the septum premium. It's this green color. It's a septum that goes from into the endocardial cushion, from the upper side into the endocardial cushion to create the interarterial septum is the green thing, and it does have some holes that should be closed by time. But when the baby develops, and that means this septum premium is going to regress, and something else starts to occur, and that is the blue color. This is the septum secundum, as we said. And if we remember, the original opening is called the ostium premium, the original opening before the creation of septum secundum, so it's called ostium premium. And then the new hole that will form is going to be called ostium secundum, and that is after the formation of septum secundum. So this is just a quick recap of what we have already talked about. If we go back, then there you go. So the ostium secundum, that means the secondary hole, the hole that was created in the septum secundum, is the most common cause, and usually it is an isolated finding. So it says that the ostium premium defects rarer and usually occur with other cardiac anomalies. So if we find the ostium premium, if the problem was the ostium premium, not the ostium secundum, that means it's just a more rare finding, and it happens with some other cardiac anomalies. Symptoms range from none, like having no symptoms at all, to heart failure, or someone who could present with heart failure. Distinct from patent foramen ovale, which is due to failed fusion. So what makes it different from the foramen ovale, which is also an opening between the right and left atria, is because the foramen ovale is a failed fusion. So two pieces just cannot connect to each other. That's the problem with foramen ovale. But in our case, in the atrial septal defect, it's a problem with this ostium secundum, which is already an opening. So it's an opening having a defect, an already existing opening having a defect, not closing properly. But the foramen ovale is just a failure of fusion of something that should have been fused normally. So for the O2 saturation that increases in the right atrium and right ventricle and pulmonary artery may lead, this is quite normal, as we said in this image, normally, because it's between the two arteries, so it's coming, the blood coming is this way, and it comes oxygen, they have an oxygen, so here it increases the oxygen concentration. Well, it should not have oxygen, or here also it would have oxygen because the opening is this way, so blood goes this way, then goes into the pulmonary artery. So this may lead to paradoxical emboli. That means systemic venous emboli uses ASD to pass lungs and become systemic arterial emboli. This is associated with Down syndrome. The paradoxical emboli, it's also basically the same concept. So there is a systemic emboli that is coming through the superior vena cava or through the inferior vena cava, coming into the right atrium, and then if it goes as it's expected into the right ventricle, then it would go to the pulmonary circulation and stop in the lungs. But what happens in case there is ASD, it will not go into the right ventricle. It will not go there because there is already an opening over here, so it goes immediately into the left atrium. It's not showing in this image, it just below these arteries. So from the left atrium would go into the left ventricle, and then the left ventricle would take that small emboli into the aorta, and the aorta would take it to the systemic circulation, and that's how we can have paradoxical emboli. This is associated, of course, with Down syndrome. So for the other disease, we have patent ductus arteriosus. It says that in fetal period, shunt is right to left. That is normal and expected in fetal period. But in neonatal period, after the baby is born, there is decrease in pulmonary vascular resistance, leading to shunt becomes left to right. That would cause a progressive right ventricular heart failure. It's right ventricular hypertrophy and or left ventricular hypertrophy and heart failure. It's associated with continuous machine-like murmur. Patency is maintained by prostaglandin synthesis and low O2 tension. If it's uncorrected, so it's patent ductus arteriosus, it can eventually result in light cyanosis in the lower extremities called differential cyanosis. For the PDA, it says that it's normal in utero, but normally should close only after birth, so it should be there in utero. And this normal shunt should be in the fetal life from right to left, as it says here. But let me explain how does it change after birth. So let's go to the fetal circulation. Oh, that's a long way to go. That's faster. There you go. So let me delete all of this. So this is the patent ductus arteriosus. It's a connection between the aorta over here and then the pulmonary artery over here. So this connection normally, as it seems by the arrows, it goes from the right side into the left side. So it's basically connecting the blood in the pulmonary artery with the blood into the aorta. It's going into the aorta. So this is the way. Okay, so that's normal. Why is that happening? Because this pulmonary artery is ending in the lungs. So these are the two lungs. This is the fetus. This is before birth. So these lungs, they're attached, as we said, to the pulmonary artery. before birth, they're filled with fluid. The baby did not take a breath yet, so they have no oxygen. If they have no oxygen and it's already filled with blood, then they do have high resistance. Like they're filled with fluid. So basically, it's really hard for this blood in the pulmonary artery to go into them and get oxygenated. They don't even have oxygen. So poorly, the pulmonary artery has no other way beside, or the only outlet it has is just to go abnormally into the aorta, and that's why it's considered a shunt from the right side into the left side. So that's normal, that's before birth. After birth, what happens is that this baby will take a breath for the first time, happily. So what happens is all of this fluid inside the lungs just will go away and it will be changed with O2. So these lungs now, after birth, they have oxygen. So if they have oxygen, that means their resistance just is reduced. So they don't resist the pulmonary artery anymore. They just don't resist it. They're saying, welcome. We're happy to oxygenate you. So the blood is coming normally from the pulmonary artery into the lungs. And so if the flow of blood is welcomed from the pulmonary artery into the lungs because they have low resistance after birth, then there is no need for them to go into the aorta anymore. It's just fine. They can go into their normal place, and this is the lung. That is what happens after birth. So in that case, after birth, let's say after birth, the blood would go the opposite way from the aorta to the pulmonary artery if this is still patent, if the ductus arteriosus is still patent. And that should explain it. So that's why before birth it's called right to left, while after birth it's called left to right, if it still persists. So basically this is the image, this is the PDA, and it's there. Now, well, it's associated with machine-like murmur. It stays patent due to the effect of prostaglandin synthesis, and also with a lower O2 tension. And if it's uncorrected PDA, then it would result in probably late cyanosis in the lower extremities. That is called differential cyanosis. Now we're going to go to the Eisenmenger syndrome. So it is uncorrected left to right shunt, like VSD, ASD, and PDA. So all these diseases that we talked about that are left to right shunts, if they're uncorrected, they may end up as Eisenmenger syndrome. So there is an increase in pulmonary blood flow. There is pathologic remodeling of vasculature. There is pulmonary arterial hypertension. And then the right ventricular hypertrophy occurs to compensate. That would lead to shunt become right to left. So that's the second phase. So let's first explain the first phase. So basically, all these diseases that we talked about, they have the blood going from the left side. So this, the red arrow, they're going from the left side to the right side, whether they are between the atria or between the ventricles or just between the vessels. So they just go from the left side to the right side, which means the right side of the heart, this blue color, is going to have a lot of blood. A lot of blood is coming. It's coming through the right pathways, like superior vena cava and then inferior vena cava. And in addition to that, it's getting a blood either from the left ventricle or from the right left ventricle. Oh my God, Allah, Ya Allah. Or coming from the right ventricle. There you go. So it comes this way. That means it's getting the blue color here, the right side of the heart is getting too much blood. So that would increase the pulmonary blood flow. That would increase the amount of blood that is going to the lungs. That is called the pulmonary blood flow. And also it would lead to pathologic remodeling of vasculature. So that will end up as pulmonary arterial hypertension. So after all of that happens, then the right ventricle is this poor guy here who is having a lot of blood. That is the right ventricle is needs to go under modification to deal with all the blood that is coming into it. So that's why the shunts now, because so it goes into hypertrophy. So now there you go, the wall gets bigger, so it goes into hypertrophy. When the wall gets bigger, that means it's now stronger than the left ventricle. This right ventricle is stronger than the left ventricle. So that would change things around and make the blood go from the right ventricle into the left ventricle. So that's completely the opposite. And that is the blue arrow over here. So that's the normal, that what happens at first, this is first, and this is what happens at second. So it's the red arrow first, and then after a while, after this gets hypertrophied, it goes into the blue color arrow. So when right ventricle gets stronger than the left ventricle, this causes late cyanosis and clumping and polycythemia. So the age of onset of the age of this starting to happen, it varies depending on the size and severity of initial left to right shunt. It depends on where is that shunt located and its severity of the very first left to right shunt of the primary shunt that happened. Where is it and how severe it is. So this is an image of the clumping, as we can see here. Yeah. And that's it for the ASM Minger. Okay. Now for the other anomalies. The other anomalies, we have the coarctation of aorta. So basically it's aortic narrowing. So coarctation, like arcutation, is close to an arc, so it's aortic arch. It happens in the aortic arch. That's so just a way to memorize it. So aortic narrowing near insertion of ductus arteriosus, and that's why it's called juxtaductal, associated with bicuspid aortic valve and other heart defects, also Turner syndrome. So basically there is aortic narrowing, as we can see here, that's abnormal. So this is considered narrowing. It's where the insertion of ductus arteriosus, bicuspid aortic valve should have 3 cusps, but in this case it's associated with 2 cuspids, like 2 cusps, the aortic valve having 2 cusps. Also with other heart defects and Turner syndrome. So hypertension in upper extremities, it would cause hypertension in upper extremities, while lower extremities could be cold and weak with delayed pulses. That's because there is a difference between upper and lower. That is called the brachiofemoral delay. So there is a delay with the blood going to the upper side and the lower side. So with age, the intercostal arteries enlarge due to collateral circulation. These arteries erode ribs and notched appearance on chest x-ray. So what happens is that the body needs to do something to overcome this constriction over here. So it starts creating new circulation called the collateral circulation. So these arteries they erode the ribs. They're just so close to the ribs. That's why they would look like as notched on. They do have a notched appearance on chest x-ray. The complications of the coarctation of aorta include heart failure and then increased risk of cerebral hemorrhage, especially the perianeurysm, and then also aortic rupture and possible infective endocarditis. So increased risk of cerebral hemorrhage, the perianeurysm, and the heart failure with aortic rupture and possible infective endocarditis.